moderating. But before we start, I just want to hand over to the president of the guild for his words of welcome. Thank you very much. Over to you, sir.
Thank you very much, Sandy. Just very briefly, what's going on there? Just very briefly, I'm pleased to welcome everyone to this meeting, and I can't wait to hear what Dr. IKPAKWU wants to tell us, because I'm rather fascinated by the choice of the topic. And so I'm sure he has something up his sleeves which is going to unravel to us. So I welcome everyone. I thank him. I see Dr. IKPAKWU, EMEKA IKPAKWU is the name, but I see on your system you have Elewa IKPAKWU, Elewa.IKPAKWU. So maybe you will just clear that when you start your presentation. Pleased to meet you. I know you are one of us. And I can tell from some people that are on the platform that you had your roots in Port Harcourt or something like that. So, so you are welcome, and thank you for joining us. Over to Dr. Dushote for the meeting. Thank you very much.
Well, good afternoon, everyone. Like some of us know, I'm actually passionate about allergies. So when I was asked by my friend to moderate this, I was excited to do this. So to speak to us today is Dr. EMEKA IKPAKWU, who has basic undergraduate training in Port Harcourt, medical in physiology and MBBS, and then he actually obtained his membership, or what we call membership in, or part 1 of membership of secretary, before he decided to move Jackpot, as we say now, to the UK. And actually completed his training. He has membership in Royal College of Paediatrician and Child Health and honorary fellow of Royal College of Physician and Child Health. He also had a diploma in allergy, and I know Southampton is one of the very active centers for allergy in UK. Presently, he works at the Consultant General Pediatrician in Royal Lancaster Infirmary, and with special interest in pediatric allergy, pediatric gastroenterology, and eating disorders and child protection. And I believe that we're going to have an exciting time. So over to you, Dr. IKPAKWU. Go for it, sir.
Thank you very much, Dr. Odushote, for the warm introduction. I have to say that here we're used to first names. We're used to first names. My first name is actually EMEKA, and my middle name is Elewa. But in the course of getting a passport, getting my registration, the names were swapped. Hence, in the system, it's Elewa that you see, but the first name is actually EMEKA. And I did train in Port Harcourt, and it's good to know that some of my colleagues from back then, Petronilla is one of them, is here. I'm really honored to be asked to talk to you guys, and I have to admit that I'm sure there'll be people with different levels of experience in allergy. So this talk I kind of made to be basic. So forgive me, please, if you are very experienced and you think this is a bit too low for your experience. I think the reason why I did this is because I know that allergy is very easily confused. People think it's very easy. You get a reaction to something and it's allergy, and then they start going down the allergy route. So for me, I think the key point in allergy is to understand the mechanism behind whatever we are seeing, bearing in mind that a lot of the things that we see in allergy can also be non-immunologic and hence non-allergic. So please forgive me. So if you think this is a bit too watered down for your experience, can you? Yeah, it's moving now. Yeah. So just as an opener, really, this is the kind of thing we see here, in the sense that food labeling is a big issue. and you get things like a packet of peanut telling you may contain traces of nut, and that can cause, and then other things, practically everything may contain traces of nut. So this is kind of a bit of an irony here. So I'd like us to go through definitions, mainly done by the World Allergy Organization. Look at allergic diseases in general, talk a bit about epidemiology, prevalence, and the concept of the allergic match, and then look at pathogenesis and pathophysiology. And then the main thing really is the diagnosis of allergy, how to manage allergy, and then also, if we have time, mention a few cases, and also give time for questions and answers. So allergy is a type of hypersensitivity reaction. And what are hypersensitivity reaction? Again, this is very basic, so forgive me if you're an immunologist and you think this is a bit too simple. Basically, hypersensitivity reactions are reproducible symptoms and signs that are initiated by defined stimulus at a dose that normal people would tolerate. And my anecdote for this is, and again, if you don't drink, please, no offense. If we went out for a drink, if we all went out for a drink and we had 10 pints of beer, 10 bottles of stout, for instance, we will all get drunk. You know, you only not get drunk if you're really a chronic alcoholic. But then we would, kind of manifest signs of being drunk. But if we all went out and had a pint of beer, and then somebody started showing signs of being drunk, that person can be regarded as showing signs of hypersensitivity to alcohol. So that was a simple way of looking at hypersensitivity. And what is allergy then? Allergy is immune-mediated hypersensitivity, which can either be IgE-mediated, non-IgE-mediated, or a combination of both. So anything hypersensitivity that is immune-mediated has now been reclassified as allergy, and that's dating back to 2009 by the World Allergy Organization, and that's been updated recently in the ICD 11 classification. And these conditions, these symptoms that we see in allergy are triggered by substances that a subject has been exposed to. So there has to be a previous exposure and sensitization before you can then go on to have symptoms of allergy. And what is sensitization? Again, that often gets confused with allergy. So sensitization is that you have an underlying immune mechanism proven in vitro or in vivo, where there is specific IgE. So IgE antibodies produced against a specific agent, which is an allergen, a foreign body, which is an allergen. Or you can demonstrate T lymphocyte production against that allergen. And this has to be associated with a compatible clinical history for you to have allergy. So sensitization is different from allergy. Sensitization means you have a predisposition to having allergy because you have been primed, so to speak, because your body has built up IgE against specific agents or some T cell mechanisms that are in place that would then lead to symptoms when you are re-exposed to the agent. And what about atopy? That's again another word that gets bandied around. Atopy is a personal or family tendency to develop IgE antibodies in response to allergens. And then what are allergens? Allergens are usually proteins or protein bound with other substances. Atopic diseases, on the other hand, well, again, are the development of typical symptoms of asthma, rhinoconjunctivitis, or eczema in people who are already predisposed. This can happen in isolation, where you have an individual with either allergic rhinoconjunctivitis or eczema, or a combination of the conditions. And in fact, this goes through different causes with age. So in a nutshell then, so allergy is a type of hypersensitivity reaction, which is specifically immune-mediated. And the confusion here is that a lot of the symptoms you see in allergy, you can always see in non-allergic conditions. So that's why it causes the confusion. That's why we need to understand where the symptoms are coming from, and to be able to narrow down our treatment, investigation and treatment. So for instance, if you go down the allergy route, which is immune mediated, it can be IG mediated, as we mentioned before, non-IG mediated, or a combination of IG and non-IG mediated. Now the IG mediated responses are the traditional, hypersensitivity reactions, type 1 hypersensitivity reaction. But over time, it's now been accepted that other immune mechanisms other than IgE mediated mechanisms are also allergy. And these ones are collectively known as non-IG mediated conditions. And again, like we said, if you have atopic condition, you can also have non-atopic conditions. So in the ICD-11, which was updated in 2016, these are the conditions that are listed as allergic conditions. So you have anaphylaxis, which we shall touch on briefly in following slide. You have, and I put them in alphabetical order, so it doesn't really represent the frequency or prevalence of these conditions. So you have asthma, you have anaphylaxis, you have asthma, you have conjunctivitis, which often goes hand in hand with rhinitis. So you have rhinoconjunctivitis. Dermatitis, you have atopic dermatitis, contact dermatitis, drug hypersensitivity, food hypersensitivity or food allergy, the venom or insect sting hypersensitivity, which may be local or generalized. And then you have urticaria, which often goes hand in hand with angioedema. Now, like I said previously, all these manifestations can be allergic and also non-allergic, and therein lies the confusion. So if we home in on allergy, then we might be misdiagnosing and mismanaging patients. What about anaphylaxis? Anaphylaxis is a severe, life-threatening systemic hypersensitivity reaction. So in effect, this is the most severe type of hypersensitivity reaction that you can have. It is rapid in onset with potentially life-threatening airway, breathing, or circulatory problems. So basically, this is the most severe. You have airway and or circulatory compromise. It is usually, but not always, associated with skin manifestations as well, skin and mucosal manifestations. So it's very, very unlikely for you to have an allergic anaphylactic reaction without showing signs of, cutaneous or oral mucosal manifestation, but it can happen. But like we said, anaphylaxis can be allergic or non-allergic. Now, this is the definition that we use in Europe and the UK. I know in a recent conference that I went for, I think a few years ago, and there were presenters from America, and for them, any systemic generalized manifestation of allergy is anaphylaxis. For us, it has to be airway and circulatory compromise. They have to be involved. In terms of prevalence, this is a very old thing, old study I quoted here, which is Isaac. I think it's been overtaken by Ventnor. But you can't talk about allergy without talking about you can't talk about the epidemiology of allergy without talking about the Isaac studies. So essentially, in the late 20th century, people tried to look at prevalence of allergy worldwide, and they felt that in the previous 4 decades, the incidence had gone up quite a lot. People were using the term epidemics of allergy. But then comparing studies was difficult because of variation in methodology. So the International Study of Asthma and Allergy in Childhood, ISAC, studies were initiated to examine the prevalence of childhood allergic conditions worldwide simultaneously in different centers. And they are kind of the most authentic figures that we have or we had at the time. But just in a nutshell, in 2008, a systemic review of published data of wheeze, just looking at wheeze, showed that the UK had the highest prevalence of wheeze in children, whereas Ethiopia had the lowest. So the pattern then was that asthma and wheeze was much more prevalent in industrialized nations compared to non-industrialized nations. But I think with industrialization and improvement in environmental conditions in the West, I think subsequently the less developed countries are kind of catching up, or in fact almost overtaking people in the West, where in the prevalence of just talking about wheeze and asthma. And this is the Isaac thing I was talking about, but I won't dwell too much on it. But I think we would have to accept that things would have changed now, and that the developing countries would have much more problems with asthma and allergic conditions than they used to have previously. So this, again, looking at the mass cohort, which is a cohort of children born in Germany, looking at the different ages, allergic condition, eczema, food allergy, asthma, and rhinitis in the different ages. And what was found, and is still true till date, that food allergy, and so food allergy is the red, and food allergy and eczema tend to start very early in life, and then kind of the incidence falls as people get older, with asthma and rhinitis taking hold subsequently. And this kind of led to the concept of the allergic match, where people have seen that there's a kind of a natural progression in one individual from having, in some individuals, from having eczema, there's atopic dermatitis and food allergy when they were young, and then that would then kind of get better as they get older, and then they will now become asthmatic and have allergic rhinoconjunctivitis as they got older. So this is still fairly applicable even today in some of the patients that we see. So why do people become allergic then? I think this would apply to quite a lot of chronic conditions. And I tell medical students, just say, for any chronic condition, especially the autoimmune ones, you have genetic predisposition with environmental factors interacting to then give you the condition that you have. So allergic and hypersensitivity conditions fall under that kind of pathogenesis as well. So the same as in autoimmune disease, generally infections, neoplasms, and so forth and so on. So drilling down to allergy, the role of environmental factors is well demonstrated, but which ones in particular is very difficult to prove. So you have your genetic, if you look at airway hyperresponsiveness and skin disorders to start with, things like perinatal maternal factors, respiratory infections, tobacco smoke exposure, pollutants, allergens, prematurity, diet, and climate have been involved. They've been implicated to various degrees. And two that I have highlighted, hygiene. There's almost a romantic, kind of view on the hygiene hypothesis, where it is thought that because we have become, especially in the West, we have become much more hygienic, our immune system has been skewed from dealing with infections as the Th1 type reactions to allergy, which is the Th2 type reactions. Now, I mean, this is very attractive. People made a big deal out of it, but in actual fact, you do see children raised in farms. I think initially they thought because children raised in farms were less affected by allergy, and in fact, in the third world as well, where perhaps people weren't as hygienic as they are now. That's only the reason why, the prevalence of allergy was less in that kind of setup. But we have seen patients raised in farms that have come with all sorts of allergy. Breastfeeding is another thing that is been linked, but again, not consistently, because if you look at cow's milk protein allergy, for instance, a lot of breastfed babies do end up with a cow's milk protein allergy as well. But in a nutshell, these things have been considered as potential environmental factors that can affect allergy. So going back to the mechanisms behind allergy, again, we said previously that any adverse reaction that you see may be immune-mediated or non-immune. So I've used that, if we use food as a particular case, and maybe drill down to, so if you look at food, in a child who is presenting with symptoms related to food, if it's immune-mediated, that's food allergy. If it's non-immune-mediated, you're looking at things like metabolic factors, fructose intolerance, lactase deficiency, galactosemia, pancreatic insufficiency can give you symptoms. So these are not immune-mediated. These are enzymatic and metabolic factors. Similarly, some of the foods have pharmacological agents that can give you symptoms. So histamine, infused tyramine, caffeine, for instance, if you drink too much coffee, you're going to vomit or have diarrhea. That is a pharmacological effect and not allergic, immune-mediated. So you also have the toxic effect of food poisoning and things like that. And other things like panic attack, anxiety, reflux in babies can give you symptoms related to food, which are not immune mediated. And that's where you have all the confusion, what exactly is going on. So if you look at cow's milk protein allergy specifically then, so if a child came in with symptoms secondary to cow's milk, we can look at it broadly, into two broad categories. One is allergic, which is immunologic, non-allergic, which is non-immunologic. Then if you go down to the allergy side of things, it could be IgE mediated. Again, we shall talk about the symptoms of how we differentiate between IgE and non-IgE. It could be non-IgE mediated, and it could be a mixture of the two. And then if you drill that down, you can have in IgE-mediated urticaria angioedema. Non-IgE-mediated, you can have diarrhea, you can have blood in stools, you can have reflux, you can have abdominal pain. And then the mixed type reactions tends to be eczema and asthma. If you go to the other side of things, the non-allergic mechanisms, metabolic factors will be lactose intolerance, for instance. Now, there's a talk that I give regularly to my juniors here, which is cow's milk protein allergy versus lactose intolerance, because those are often quite confused. So galactosemia, those are enzymatic or metabolic mechanisms. And then we talked about reflux, which is, again, a host factor. Child's lower esophageal sphincter is not fully developed, and they're drinking milk, and that's why they are prone to reflux. So that's kind of a broad way of looking at allergy, particularly when it comes to food. And the same applies to any allergy, airway allergy, respiratory allergy, skin allergy. So again, without wanting to teach people basic immunology here, again, if you look at, we've mentioned that you've got to be sensitized, and then and that sensitization would predispose you to having an allergy. Now, IgE-mediated allergy, the symptoms are usually within minutes up to a few hours, 4 hours, maybe slightly longer. Involves mast cells and histamine release, mast cell degranulation and histamine release. The non-IgE ones tend to be, delayed. They tend to take hours, days potentially, and they involve eosinophils, T cells. So anything other than IgE would be non-IgE mediated, and you have an overlap between the two sometimes. So what are allergens? Allergens are proteins usually. They possess allergenic activity both in vitro and in vivo. They may be low molecular weight, like in drugs where they have to bind with proteins and then cause problems. They react directly with T cells to either induce, for instance, in contact dermatitis, or they can react with B cells to lead to IgE production. So examples will be, classified into different Roots, inhalants will be indoor. You have house dust mite, cat, mouse, rat. Cockroaches is not a big thing here in the UK, but I know that in America is a big thing. I don't know about Nigeria. Outdoor allergens will be pollens, grass, tree. Again, depending on where you are, you might have Timothy grass, birch tree. Lettuce allergy is also is another one. Food, the commonest allergens that we see will be milk, egg, codfish, peanut. Venoms, bee, wasps, fungi, aspergillus. But practically any protein can give you allergy. So people can react to anything, to be honest. Again, we talked about the sensitization phase where your allergen then goes through dendritic cells, which are allergen presenting cells, present the allergens to T cells, and the T cells will then produce some mediators, which would then stimulate the B cells. So this is type 1 hypersensitivity reaction. B cells to produce IgE. The IgE sit on mast cells, and then when the individual is then exposed. Now, so this is sensitization. When you have produced specific IgE to particular allergens, they go and sit on mast cells, and then with subsequent exposure, the allergen molecule would cross the trouser legs of the IgE and then cause mast cell degranulation, and then the effector phase, which is your symptoms. So symptoms, for instance, of food allergy would depend on the systems that are involved. So again, we can distinguish between immediate symptoms, which will be within a few minutes to a few hours, and delayed symptoms. For instance, gastrointestinal symptoms, you have vomiting and diarrhea, oral allergy syndrome, and these are usually immediate, within a few minutes to hours. For IgE mediated, you can have the more difficult and indolent ones that are much more difficult to diagnose: vomiting, diarrhea, blood in stools, difficulty in feeding, abdominal pain, failure to thrive. So the problem here is that because these things can be caused, these same symptoms can be caused by other things, you're kind of wondering, is this allergy or not? Cutaneous symptoms would be urticaria, angioedema, rash of any kind, really flushing, a flare, immediate flare of eczema in IgE. Again, worsening persistent eczema, contact dermatitis will be non-IgE. Respiratory, we've talked about rhinoconjunctivitis, which we call hay fever here. You can have cough, you can have laryngeal edema or bronchospasms. Again, immediately following the symptoms will be IgE. Worsening or persistent asthma will be delayed. And we've talked about anaphylaxis, which is the most severe systemic reaction that you can have that would involve airway, compromised breathing problems, and or cardiovascular compromise. So I've just put a picture here of urticaria, which is hive. They are raised lesions that are itchy, very itchy. So when people come and say, "Oh, I've got a lesion and it's not itchy," then probably not urticaria. Then that's angioedema, swelling. So how do you diagnose allergy? I think that's the key thing, really. We often get, I mean, I've mentioned in the case, a few cases that I have here, we often get referrals, "Oh, this child has got allergy. Can you do some allergy tests?" And I tell them, we don't do allergy tests in the allergy clinic. What we do is we do a comprehensive allergy assessment. And I say that 90% or even more of the diagnosis is based on history. So history. Obviously, the history will be history of the symptoms they were having, trying to find out how they relate to the exposure that we are worried about, the timing of that, and the actual nature of those symptoms. Obviously, we examine the child and then we'll consider whether a test will be necessary or not. Bearing in mind that the tests that are available for clinical practice, in clinical practice, are just tests for sensitization. There may be other tests in research settings, but for clinical, in the clinical setting, you have tests of sensitization, which can be either you do a skin prick test or you do serum-specific immunoglobulin. Basically, you're just looking for evidence of IgE to specific allergens. You can drill down the IgE levels by doing component resolved diagnostics, looking for the specific isotypes that are responsible for the reaction. You can also do a trial of allergen elimination, and that will usually be much more relevant for the delayed type allergy because you don't have any tests to do. So the only thing you have really, if you're convinced, is to eliminate that suspected allergen. And we say that if you've eliminated religiously, because it can be a problem to eliminate stuff religiously, but if you've done that religiously for 4 to 6 weeks and there's no improvement in symptoms, then it's probably not that urgent. The difficulty here is, for instance, eczema. Eczema does flare, quite a lot in response to a lot of endogenous and exogenous factors. So if you're avoiding something, if you're worried that something might be related to causing your eczema or making your eczema worse, and you're avoiding it for 4 weeks, it's very likely that within those 4 weeks, your eczema might get better or worse due to a lot of other factors. So it becomes much more difficult then to pinpoint that response or the change that you're seeing and say that this is due to elimination of a particular allergen. In clinical practice, we rarely do provocation challenge. We do that most of the time just to reassure people that they are not allergic, but that's there. I mean, that's the gold standard for diagnosis would be provocation challenge, double-blinded placebo-controlled challenge, but it can be quite difficult to do because you've got to mask the food. Masking mean you've got to mask the taste, the smell, the look, so it can be quite difficult. Another test that we have will be looking for evidence of anaphylaxis because we know anaphylaxis will be associated with significant mast cell degranulation. So you look for mast cell tryptase. So you do an acute level within a few hours of the reaction, and then do a baseline level more than 24 hours later. Also bearing in mind that some people might have mastocytosis where they have very high level of mast cells anyway, and those may come up with recurrent urticaria. So what are you looking for in the history? So the history helps you to determine the pretest probability of allergy. So basically, if the history, in my practice, if the history is not suggestive of IgE-mediated allergy, then I will tell you there's no point doing a test, okay? Because the test is not going to help me. So the history would actually tell you whether you need a test or not. So the history will tell you what allergy you're dealing with, if you're dealing with allergy, and what you're likely to expect from the test. Things to look out for in the history with nature of the symptoms, temporal relationship with exposure, response to treatment, previous exposures, possibility of cross reactions, and personal history of atopy, family history of atopy. The main points about tests in allergy, in fact, as an allergist, I end up doing less tests than non-allergists, honestly, because we know that a lot of the children don't have allergy to start with, or they don't have IgE-mediated allergy, so they will not need a test. So you only do a test when clinically indicated because interpreting tests in isolation can be difficult or if not impossible. So we get children that come in, they've gone privately and done tests, and there are quite a lot of high street tests there, tests that are done in high street that are not science-based. So they come in with those and say, look, we say, well, we don't believe in all these tests. Or they do a proper test, but without a history to back that up, it's very difficult to make anything out of it. Okay. A positive allergy test taken in isolation, like I said, is meaningless. You have to have a consistent history for that test to make sense. So history and science for that test to make sense. For patients with food allergy, the history is most important factor in determining if a test is necessary or not. And we try to avoid panel tests. We try and focus on the allergen that is in question. So if you come and say you had a reaction to peanut, I would try not to test you for hazelnut. I'll ask you whether you've eaten hazelnut before, and if you've eaten it before, then that tells me that you don't have allergy to hazelnut. The only time we must do another test is if you come with cashew nut allergy, then we would test you for pistachio because they are both very closely related. The same with peanut and pecan nut. For patients with inhalant allergies, again, people have hay fever. Honestly, whatever your allergy test shows, they will be treated for their hay fever. Similarly with asthma, you need to treat them for the asthma. So you do allergy tests in those cases where the symptoms are very severe or not responding to treatment. And in that case, you might consider a panel of tests, but not necessarily with food allergy. So just a comparison between skin prick test and specific IgE test. Both of them are tests for sensitization. So you're looking for IgE. So serum specific IgE test for circulating IgE in the blood, and skin prick test for IgE in the skin. So the skin prick test is the usual first thing we do because we can do that in clinic and read it off in a few minutes. And that visual cue that you get, so you're doing it, you're showing them your skin has responded or not responded, is quite impactful. The serum specific IgE we do usually a second line to validate maybe the skin prick test if you need to, or if there are contraindications to doing a skin prick test. For instance, if they had antihistamine or steroids, systemic steroids just before you saw them. So we usually say avoid oral antihistamine for at least a week before we do the test. That would be much longer for systemic steroids. The skin prick test is semi-quantitative. The serum-specific IgE is a bit more quantitative, but people have looked at the correlation between skin prick test and clinical allergic reaction. So, for instance, for peanut, skin prick test of 8 millimeter correlates more with having clinical allergy, whereas the figure for the serum-specific immunoglobulin for peanut is about 18 international unit per liter. So bottom line is that we tend to do more of skin prick test, which is right away you do it, you get your result, you discuss the result with the patient, and you make a plan, management plan based on the history and the result. So that's kind of a photo of a skin prick test. So we drop extracts on the skin and use a lancet to probe the skin, introduce that into the skin, and we read off in 15 minutes. A positive test is, so we do a histamine control, which is a positive control, negative control. And a positive test is 3 millimeters above the negative control. So if your negative control, which is saline, is 0, anything 3 millimeters and above is a positive test. If your negative test is 5, so you have to have a minimum of 8 millimeters to have a positive test. So I did mention component resolved diagnosis. This is kind of drilling down into the different components of the food protein that gives you the different types of food protein that can give you symptoms. So for instance, peanut, you can't do the whole peanut serum specific immunoglobulin. But if you went down to looking at the isotypes of the peanut protein, so talk about RH1, the usual ones with the RH1, 2, 3, 4, 6, 8, and 9 will give you information about whether you're dealing with primary peanut allergy or whether you have a high risk of having a significant reaction. I'll come to that in the case that I'll mention later. But this is something that's come in the last few years. Oral challenge, like I said, is the gold standard for making a diagnosis. It's not easy in clinical practice, especially if you're doing double-blinded control, placebo-controlled full challenge because of the masking. But we tend to do more of open challenges. So we do that when the history and tests are a bit equivocal or ambiguous presentation. And then you might want to establish the significance of cross-sensitizations. For instance, if a child has oral symptoms to peanut, then you can do a food challenge to peanut to see whether they actually have primary peanut allergy or not. But you have to do the serums, the component resolved diagnosis. In my fourth case that I've mentioned, I'll talk about that. So assessing the possibility of development of tolerance. So if the child, I often say that, especially with cow's milk and egg allergy, is not a life sentence of allergy. Children do outgrow these, and we get to a point where we want to reintroduce these foods with or without doing a food challenge. Usually with the IgE-mediated symptoms, yes, you might do a food challenge, but with non-IgE-mediated symptoms to these foods, then we usually say introduce the foods at home using gradual approach, which we call milk or egg ladder. Sometimes parents insist, you've done a skin prick test, which is negative, you've done serum-specific immunoglobulin, which is negative, and they insist, no, I'm not going to give my child this food because I'm not going to kill my child. Then you can't do a challenge. Now, remember, how these things are done may be a bit different in private practice. And I understand that you guys, I recognize that you guys are mostly private practitioners. But what I'll do in hospital, in the NHS, will be different from what people do sometimes in private practice, because private practice is, as you know, motivated by the patient's ability to pay. So if patients come saying, I want this, I want this, I want that, I'm ready to pay, they often get these tests that may not be necessary. So just in a nutshell, because I'm mindful of time, in a nutshell, the diagnostic approach, you have to take a history, and the history will tell you whether you're dealing with IgE-mediated, non-IgE-mediated, or if it's not very clear, you only do a test. I'll do a test for skin prick test, for instance, if it's IgE that we're talking about here. If the history is not suggestive, then I'll exclude the allergy. If it's still unclear after doing the test, then you might do a provocation, challenge, or elimination. So if we just break that down, if you're looking at peanut, for instance, if you look at a peanut allergy, this is from the British Society for Allergy and Clinical Immunology. I put the resources at the end, and they're actually free to access. So if you go to this website, you would get a lot of guidelines for free. So if you look at peanut, for instance, a patient comes in with a history. You go through the history with signs, symptoms, and signs. You go through the history, and you decide, oh, this is typical peanut allergy history, all right? So you go down the left, and you do a skin prick test or serum-specific immunoglobulin to peanut, whole peanut. And if the skin prick test is less than 3 millimeters, and serum-specific immunoglobulin is less than 0.35, that's kilo unit, is kilo unit per liter. Sorry, not international unit, kilo unit per liter. I think I did mention figures previously, it's kilo unit per liter. Then you might consider a challenge. Now, the British Society for Allergy and Clinical Immunology will tell you do a hospital challenge, but in actual fact, it's very difficult to get, the waiting time for these things are so long. If the history is not very strong and the tests are negative, then you could encourage the parents to do a challenge at home. Now, if the history is suggestive of food pulling syndrome, which I'm going to mention later, meaning they mostly have oral symptoms, right? Again, if you did your skin prick test and IgE, depending on the level, you can make that diagnosis, okay? If it's unclear, then again, you would do if the history is unclear, you do your test, and that's where component resolved diagnosis comes in. And then you do your RH2, RH8, depending on the level, then you might consider a challenge. Again, I'm going to talk about this in a case that I'll mention later. So how do you manage allergy? Education, information is the key, right? You've got to educate them, let them know, we have all these resources, we send them to the website, we print out leaflets. I work with an allergy nurse specialist who goes through the education with them, management plan with them. Clearly, the main treatment for allergy is allergen avoidance or exposure reduction in patients with inhalant allergy. So this would involve teaching them how to read food labels. Now here, the European Food Standard Agency, they have specifications for how to label food. So I think I'm just looking it up now. There are about 14 different foods that you have to specify if they are present in the food. So, I mean, all the known allergens, egg, cow's milk, oat, wheat, barley, so forth and so on. You have to specify that in your label. So these are foods that are manufactured in the factory, right? And patients are taught how to read these labels, how to look out for these. So if you've got peanut allergy, for instance, you have to look up labels of crisps, everything with, and if it has peanut, it has to be boldly written on it. So the problem is when, I mentioned earlier that you have may contain. So a lot of foods will say may contain this and that and that. And we usually say, if that food is not listed boldly on the ingredient list, then we assume that the food is not in that, that food agent is not in that food. For instance, if you have a chocolate, a bar of chocolate that says may contain peanut, and you go and look at the list of ingredients and there's no peanut, you can assume that there's no peanut in that. Obviously, they may say may have been made in a factory where peanut is made as well. So usually what we say is try the food at home, obviously with your antihistamine ready, and if you're able to tolerate it, then you can eat it outside. But if you tell patients to avoid everything that says may contain peanut, they are just going to be running around scared. So they won't be able to eat anything. All right? So you have to teach them how to reduce exposure to house dust mite, pets, pollens. Pets is a very sensitive issue here. People regard pets as part of the family. So people have cats and dogs that they've had for like all their lives. And these cats and dogs are insured. They go to the hospital if they are sick. And if they die, they have funerals for them. They buy them Christmas presents. So for you to say, oh, get rid of your dog or cat, you're just going to make enemies of these people. So we're very sensitive about that. So unless your symptoms are uncontrollable, and we usually will say we don't go near pets unless your symptoms are uncontrollable. And if you've not got the pets, then we can say, it might not be a good idea to buy to have pets. But there are very few families here, Caucasian families that don't have pets. African and Asian families are a bit different. Okay, so the treatment of reactions, immediate reactions, oral antihistamines, we prefer non-sedating antihistamines. Management of anaphylaxis, again, there's a guideline for that. That requires adrenaline treatment. You have to control the coexisting atopic conditions. So if you have a child with peanut allergy, we know that asthma, poorly treated asthma or poorly controlled asthma is a risk factor for having anaphylaxis in a patient with peanut allergy. So you've got to treat the asthma well. So you don't just treat their say avoid peanuts, have your pen. You've got to make sure that you treat the asthma properly. Similarly, patients with rhinitis and asthma, which often coexist, you may have heard about the ARIA guideline, which is kind of the concept of the common airway. So we know that patients with asthma do better if you treat their rhinitis properly. Similarly, patients with rhinitis will do better if you treat the asthma properly. So you have to treat the coexisting atopies. Like I said, food may have to be reintroduced, egg and milk when they outgrow it. We use what we call the milk and egg ladder, which basically means gradual introduction using more processed and cooked food, then progressing to less well-cooked, for instance, raw milk. We talk about adrenaline auto-injector, the indications. At the moment, in the past, we used to hand this out willingly, but at the moment, here in the UK, the indications would be if you had a previous anaphylactic reaction or you have uncontrollable asthma. If you have peanut allergy, for instance, if you have nut allergy and you have uncontrollable asthma, or you're very difficult to reach, so you live in a remote area where it's going to take a long time for the ambulance to get you, the expectation is that the ambulance will get to you in 5 minutes. So if you give you a pen, you give you adrenaline if you're having an anaphylactic reaction, we teach you what anaphylaxis is, and then you how to give the pen, and we review you yearly to make sure that your pens are in date and review that, make sure that you know how to use it. We'll refer you to their website, their videos to be watched and all that. So if parents insist, so no, I need a pen, you give them a pen, or if they live in a place where ambulance might take too long to get to them. The reality now is that the ambulance response time is increasing. So it's not like it used to be before. So we find that we might have to be giving people more EpiPens. At the end of the day, for every patient with allergy, we do a personalized allergy management plan. Again, there's no time for me. If you go to the British Society of Allergy and Clinical Immunology website, we have the plans are there. So write your name on it, put your photo on it if possible, put your parents' names and addresses. If your oral antihistamine is loratadine or cetirizine, we'll put it there and the dose. And then we also put your pen. So there are different pens. We have EpiPen, we have Jest pen, and we have, we used to have others, but I think at the moment, I think it's Jest pen and EpiPen that we use mostly. The dose, if you're less than 30 kg, we give you two 150 micrograms pens. If you're more than 30 kg, we give you two 300 micrograms. The reason for that is that the first pen may not be enough, and if the ambulance doesn't get to you on time, you can give the second pen after 5 minutes. So do we have time for me to just quickly go through one or two cases?
Yes, I think you should go through one or two cases to enforce what you have taught.
Yes.
Okay.
I'm grateful for that. Yeah. I'll try to make it as quick as possible. All right. So I think you may have to mute yourself now. Yeah. Okay. All right. So this is a typical case that I get. Right, a 10-week-old female, bottle fed from birth, has been vomiting post-feed. It's a bit snuffly. Parents have tried treatment for Gaviscon for 1 week, and there's no response. Instead, the child became constipated. Mom is worried. They're concerned about allergy, and the GP refers to me and says, allergy test. Okay. Now, for this case, I would say, obviously, I'll go through the history, examine the child. Most patients with vomiting post-feed have gastroesophageal reflux. So the incidence of that in my own experience is at least 50%. Whereas we look at cow's milk protein allergy, the incidence, depending on how you define it, can range from 3 to 2% to 8%. So the more prevalent will be in self-reported symptoms. If you base your study on self-reported symptoms, you're going to have more people prevalent, greater prevalence. Studies done using food challenge would put the incidence of cow's milk protein allergy in the UK at 2 to 3%. So you're far more likely to have gastroesophageal reflux than cow's milk protein allergy. So I would emphasize proper treatment of gastroesophageal reflux. In this case, this patient had treatment for only 1 week. Most of them will stop it because they're constipated. I'm just going to go back and go through that with them again and probably prescribe some laxative for that child. Now, this one, a 12-year-old male, breastfed from birth, vomiting post-feeds, unsettled, again, gastroesophageal reflux. I started on Gaviscon and ranitidine, no response, and eventually developed mucus stools. Yeah, so this child was 12 weeks, mucus stools, no blood. Again, referred. The child has eczema, 4 weeks, worsening. So referred for possible allergy test. Again, now this may be allergy, but it's not likely to be IgE mediated, right? So this child has eczema. It's possible that cow's milk might be playing a role, but then they've also developed bloody stools. Yeah, often they will have blood in it. So again, it might be an infection. So you might do a stool MCS, you might explore for infection, but certainly, yes, cow's milk protein allergy is possible, but it won't be IgE mediated, so this child doesn't need any test. So if you're thinking that this is allergy, then the way to prove that would be to put them on cow's milk elimination diet. And if it is allergy, their diarrhea and may improve within a few weeks. Sometimes it can be quite, especially if they are very symptomatic, the response can be quite dramatic within a few days. But I think the point here is that this child doesn't have IgE-mediated symptoms, so you don't need to do allergy test. Now, this is a more tricky one that I saw over time. 4-year-old boy had quite bad eczema. These are the ones that give us problem, the eczema patients. Recurrent illnesses, respiratory illnesses, wheeze, and all that. There was a very strong family history of cow's milk protein allergy, dad and sibling. How true that is, we're not sure. The child was also coming out with occasional swellings. They weren't sure about the triggers. It might be spontaneous urticaria. So the parents have a long list of worries about allergy, cow's milk, egg, nuts, salmon, which they were excluding from this child's diet. This child hasn't had any definitive reaction to nuts. In fact, they've not actually eaten nuts because they've been avoiding it, all right? Had several allergy tests, positive, negative, inconsistent. They were avoiding cow's milk, egg, all nuts, and salmon. Had recurrent wheeze, conjunctivitis. Parents were so worried, they insisted on EpiPen, they were given a pen. So this child is clearly atopic, right? But we don't know what's going on here. So anyway, over time, with trying to manage this child, following them up, we were able to reintroduce fish, and was tolerating that. We started cow's milk and egg reintroduction, and again that was moving well. Eczema, wheeze, rhinoconjunctivitis were improving with time, as expected. They haven't had any wheeze now for a long time, so they were no longer on regular treatment. So we managed to introduce almond, which the child was tolerating. So parents then decided, okay, I think we would like to explore the other nuts. So we advised home challenge after skin prick tests and serum specific immunoglobulins to certain some of the nuts. I'll show you the results in a minute. But then the child ended up reacting to cashew nut, query anaphylaxis from what they were describing. Again, not very clear. So parents became very, very anxious. The child was withdrawn from school along with his sibling. So this is the result that we got here. So these are the results over time. So in 2015, when they were very young, when they first presented, this was skin prick test. So it was sensitized to peanut, almond, Brazil, hazelnut, cow's milk, and egg. Remember, this child has eczema. So all this sensitization may not necessarily mean that they've reacted to these foods, right? All it means is that they're just sensitized to the food, right? So how do you then manage this child from that point onwards? So normally what you would say at this age, they're very young, perhaps avoid the nuts, okay? Avoid nuts. Cow's milk and egg, no matter how bad you are, as long as you're not having allergy, anaphylaxis, we will usually at 1 year start reintroducing cow's milk using the milk ladder. Egg, we're even much more proactive about, because children with egg allergy, a lot of them, even at the very beginning, will be tolerating cooked egg. They may have problem with fried egg or omelette, so omelette or scrambled egg, and things like mayonnaise that have raw egg in it. But a lot of them will tolerate cake, biscuits, and other baked products with egg. So we'll say continue with those and gradually build them up. Again, if you go to the Bisaki website or one of the other websites that are listed there, which is Northwest Allergy website, you will see the ladders, the milk ladder and egg ladder. So we will say start gently introducing those foods while we are monitoring things. So a year later, had test, now for aeroallergens, because they were worried about aeroallergens. Now, hay fever and things. And at that point, was only sensitized to house dust mite. Again, doesn't really mean much. Well, we will give them advice on how to control house dust mite, but you're not going to run away from pollens. We tell you how to minimize exposure, but then you treat the hay fever. So again, how many years later? 3 years later, was this significantly sensitized to peanut by skin prick test? Cashew nut was sensitized. We usually do almond, pistachio when you are sensitized to cashew nut, whether you've eaten it or not. Wasn't sensitized to pistachio. Was still sensitized to almond, walnut, but not Brazil nut. So at the point I saw them in 2019, no, I saw them in 2021. My colleague was seeing them earlier on. But again, the pattern of sensitization fairly similar by when you did the serum immunoglobulin. So when I saw them, I did skin prick test after they expressed interest in trying nuts, and I can see that they were still sensitized to peanut, but not to and hazelnut, but not to the other nuts. So basically, if you look at over time, no convincing history of previous reaction to nuts, consistent sensitization to peanut and hazelnuts. So as to avoid those ones, we may consider hospital challenge if we go through the other nuts. So almonds has been tolerated, which was fine at one point. So no sensitization. We say, okay, reintroduce at home. Cashew, pistachio, and Brazil, no sensitization. We said, okay, do a home challenge and then reintroduce. Walnut, again, significant sensitization on previous result, but no sensitization recently. We're going to consider hospital challenge. So you can see there's a lot of juggling to be done there. But bottom line, this child went ahead and we gave them a written instruction on how to do the challenges that we wanted them to do. How to be ready for reactions if there's one. So we advised to start with almonds, which he had eaten before, which he passed and tolerated. So parents decided to go for cashew. And if we go back to that, cashew, we said cashew, no sensitization in recent results. But previous results was sensitized to cashew in 2019. But nonetheless, we said go ahead. So the child tolerated 4 cashew nuts, but 5 minutes after the 5th nut had a reaction. So what parents described to me was there was swelling and redness of the lips, eyes, face, neck, drooling of saliva, and chest discomfort. Now, so the last 2, drooling of saliva and chest discomfort, would suggest anaphylaxis, right? The other ones, lips, eyes, swelling of the face, maybe not. Neck, neither here nor there, but drooling of saliva and chest discomfort means there's airway compromise and respiratory compromise. So they should have given a pen, which they had been trained on how to use, but a lot of patients don't use it. So they didn't use it, they gave oral antihistamines instead, and the child was taken to the urgent care center where adrenaline was administered. So at that point, they became my enemies and refused to see me again. Parents' anxiety got worse, and ultimately, I had to refer them to my colleague. So it took a long time to get them back. So please, the last case, I think this is an interesting one. A 13-year-old male has seasonal allergic rhinoconjunctivitis, hay fever, was diagnosed at 5 years. We know he's sensitized to house dust mites, tree and grass pollens. He's on regular antihistamine, nasal steroids, so nasal steroid spray, and ophthalmic chromoglycate. So we treat your allergic rhinoconjunctivitis based on how severe it is. Some patients are okay with just oral antihistamine, and others will need nasal steroids and ophthalmic treatment. I tend to use sodium chromoglycate rather than local antihistamine because I feel that you're already on a lot of antihistamine, and we'll give very high doses actually. So if you look at the British National Formulary for cetirizine, for instance, is 10 milligrams twice daily for an older child, but we can give up to 4 times daily. So I feel that once you're on that, I won't be giving you eye drops with antihistamine. I prefer the mast cell stabilizers. And we can also give nasal steroids, okay? And this child also has eczema, has a previous history of recurrent week. So this child is actually atopic. Their family owned 2 dogs, but because their symptoms were well controlled and the dogs have been there for ages, we didn't bother about the dogs, so we were fine. But then more recently, they started having swelling of the lips, itching of the throat, and facial rash, usually within a few minutes of eating apple, pear, and also peanut. Does anybody know what's going on here? But they don't have any other symptoms. Any takers? So we did some. Yeah, go ahead.
No, sorry, I know, but I shouldn't answer the question.
Okay, that's fine. That's all right. So we repeated their test. So the skin prick test, positive control 5 millimeters, negative control 0. Peanut was 5 millimeters, so they were sensitized. House dust mites, significantly sensitized. Grass pollen, already we know, grass and tree pollens, we know that. Cat, dander, and dogs, but we know that the dog has been there for a while, yeah? And these hay fever symptoms were well controlled. But then this is a case for doing component resolved diagnosis. So we did the total IgE levels for peanut. We didn't bother with the aeroallergens because we've got the information that we need from there. So we did for serum spectrum hemoglobin for peanuts, and the total IgE was raised. Not surprising, this child has eczema anyway. So you can see thousands in children with eczema. That, by the way, that is the unit there is wrong. What unit did I say before? But the unit is wrong anyway. So it was raised. P naught was raised, and then these are the components. So RH1, RH2 was negative, RH1 was positive, RH8 was even high, but 3, 6, and 9 were negative. So this would suggest that this child has cross-sensitization. So with RH2 is much more correlates with primary peanut allergy and would predict a higher risk of having a significant reaction to peanuts. Whereas RH8, oh God, I didn't put RH8 here. RH8 being raised and RH2 not being positive would be indicative of cross-sensitization. So what is happening here is that the reaction that we're seeing with the peanuts and pears and all the other fruits is due to cross-sensitization between the pollens, so the pollens that this child is sensitized, so the tree pollens and the proteins in these foods, right? So this is what we call food oral allergy syndrome or food protein syndrome. So food pollen syndrome, rather. So these are reactions to fruits and vegetables and sometimes nuts. So you can have reactions to peanuts and hazelnut as well, commonly. These patients typically will have allergic rhinoconjunctivitis, and they tend to have the symptoms more during the hay fever season, okay? So especially during the hay fever season, when you have very high pollen count, that's when they tend to have these other reactions to food. They may be fine other times of the year, but then during the high pollen season, that's when they do that. And it's due to cross-reactivity between allergens in pollens and the foods. Symptoms are usually limited to the mouth, throat, and sometimes face. And the throat symptoms here is usually itching and discomfort, not difficulty in swallowing or drilling of saliva or stridor that you have with the proper anaphylactic reaction. And we know that the symptoms are mild. They may be reduced by cooking the foods. So if you cook your peanut, for instance, we roast our peanut, you may not have symptoms. But here they eat a lot of raw nuts. So I'm peeling the fruits for the apple and pears, peeling the skin. Most of the allergens are on the skin. So if you peel the skin, then the symptoms might be reduced. Okay, cooking the vegetables will have the same effect. Treatment is usually symptomatic. Now, this is not usually an indication to stop the food, especially if you've done your component resolved. For instance, in this case with peanut, now you've done your component resolved diagnosis, and you know that RH2 is negative, right? And RH8 is raised. So that's the kind of picture that you have with food pollen syndrome. But obviously, if they have like asthma, they have other allergies, then you might be better off just avoiding the nuts. So this is where component resolved diagnosis is helpful. So that brings my talk to an end, and these are the resources that are available. So I'm a member of the Northwest Allergy Network. I'm also a member of the British Society for Allergy and Clinical Immunology, and by extension, World Allergy Organization. So they have, in fact, EIK as well. So European Academy of Allergy and Clinical Immunology, they have resources that are available free of charge. So if you're really interested, go and have a look at them. Anaphylaxis UK are very particular about, this is a patient support group that are particular about anaphylaxis. There's a guideline for management of anaphylaxis, and that is from the Resource Council. Can you see that? Can you see that link? Okay, maybe I have to share that. So there's a link. If you click on that link, it takes you to the Anaphylaxis UK. Yeah, so the Resource Council UK. That's the guideline that we use for management of our anaphylaxis. So that takes you there. Let me go back to, so if I go back to my presentation. So, and then you have the World Allergy Organization. Thank you. And questions, please. Sorry, I've overrun there. There's quite a lot of things to cover.
I think you did very well. I think you did a very good job, at least. You
great.
actually gave a synopsis of allergy, and very wonderful talk. I was really enjoyed it. So we'll just ask for a few questions. You can actually raise up your hand. Or okay. Dr. Oladele, can you please unmute and ask a question?
Good afternoon, everyone. Sorry, let me just declare my, like my own conflict. So I actually am in diaspora. I had my fellowship back home, and I interested in when he mentioned Dr. EMEKA. Thank you very much. I've been trying to get hold of you, but I was hoping I'll meet you at some point.
Yeah,
so when you mentioned Southampton, it was interesting to me because I did a few months as an allergy registrar in Southampton, and then I currently I'm in general peds, but I still do like allergy clinics. So I found this very interesting because I was just talking to a colleague a few weeks ago, and I was saying that I was very interested in how much of allergy we do in Nigeria. Do we have issues around nurture and nature? Maybe kind of affecting how what our allergy prevalence is, or are we well equipped for this? So I think this was really, I found this very exciting, and I kind of just jumped on the bandwagon. So I want to say thank you very much. That was a lot to say within an hour. Okay. And I wanted to say that I was putting myself in the shoes of if maybe a few years back, if I had to take on all this talk. I don't know how much. I know there are professors here and all that. But for the younger ones, I think it's a lot to take in. But I think Dr. I don't know whether you like your first name.
EMEKA.
Yeah, EMEKA, yeah, so fine. So EMEKA has done a lot to kind of do like a whistle talk and stop talk. And I think going through the recording would do a lot. I just wanted to add something, just like he has said, that our history is a big deal, because I'm also looking at where we're coming from, where we don't have a lot of resources. And one of the things I've seen in the UK is allergy is something that really, there's a lot, you can do some testing, some of those very good testings, high fidelity and all that. But just like he said, most times it's a lot of history. Many of them come in saying, we think we're allergic to this and all, but a lot of history. And I wanted to just give an acronym, and I'm going to send a link. Maybe I could share through EMEKA when I, get in touch with him later, where we use like what we call like the EATAs. If you were in Southampton, you'd have heard it because, Mish would talk about that a lot. So EATAs essentially is like an allergy focused history where you just, there's a 15 minutes consultation. That's the paper I'll share at the end, where you look at what is the exposure. So for example, most food allergies, he's talked about a lot of things, the IG, non-IG ones, but usually the allergic ones from food, there's something about exposure. So there are very few things that would come from maybe in the air, maybe fish. There are few allergens that you can pick up from there, but most times the exposure usually with food allergies, usually through the mouth. So the first E is the exposure. So what I'm saying this is a lot of people will come with the rash and other things, and they might not be truly allergies. So this history gives you a bit of direction before you take things on. So the first one is exposure. The A in the EATER, so EATERS is what I kind of use in my clinic. And the A again is the allergen. So we need to recognize what the common allergens are in our environment. Okay, so I guess this is where the environment kind of differs. So there will be common things across, but there might be also differing things in different environments. So this is why when we group this, we can't know what the common allergens are in our environment. Then the T is time. So just like you said, the IgE one, most times from the pathophysiology, the mast cells are already sensitized, they degranulate. So typically they are within 15 minutes, half an hour, most times within an hour. If it's an oil-rich food, then it might kind of prolong it a bit more. So the time is also gives you. So if it's something that just goes on and off and all that, and it doesn't follow this kind of the timing, then it's unlikely to be, at least it's not likely to be IG mediated. Then there's the E again, which is environment. So you're likely to be more exposed to have more allergens in maybe environments like, when you're traveled, you're out, and, in restaurants where foods are not well labeled and all that. And then there's the R, this is very important, reproducibility. Okay, so if it's an allergic reaction to an allergen, then it would be reproducible until it is desensitized, right? So those are things, and then the C is like the classical symptoms, just like EMEKA had mentioned all along. So I just thought I kind of at least give a bit of focus to that allergy focus history, which is a big part of what happens in the allergy clinic. And I'm happy to share that.
Yeah. Thank you very much for that. Thank you for that. Dr. EJ Diaku, you said, how do we eliminate house dust mite? What do we do? What instruction do we give to patients? Dr. EMEKA, do you want to respond to that?
Yeah, I think house dust mite is ubiquitous. It's difficult to completely get rid of it. But we do have, I think what I might do is to share a leaflet that we have from the Bisaki website, Bisaki, about what to do. First of all, discourage having carpet. So what they call carpet here is rug. we call it rug. So having carpet in the room, because the linol or wooden floor is easier to clean, so you can clean that very frequently. Whereas if you have carpet, you really have to have vacuum very frequently. Avoid soft toys, the fluffy toys. They are harbingers of house dust mite. Wash your beddings very frequently, preferably using the hot water, the hot cycle, 60 degrees. So things like that. But yeah, you can try your best to reduce. They're very, very difficult to completely eliminate. With the other aero allergens like tree and grass pollens in the summer or spring, or even autumn, closing your windows is okay in the UK because it's very cold. So we don't need air conditioners here. In Nigeria, people are going to die of heat. So yeah, so we do have information on that. I can share the house dust mite want with you. But if I just go back to what Lola was saying, one of the reasons why I went into allergy was that I didn't know anything about allergy until I came to the UK, right? And I still say that there are a lot of other things that could kill you then in Nigeria, and allergy is probably not there on the list. So I went into allergy because I didn't have a clue. So for me to understand how it works, I felt, okay, I needed to go deeper into it. I know things would have changed now. For instance, with my eating disorder hat on, I know when I was in Nigeria, nobody had anorexia. Nobody was a vegetarian, but I have a nephew who was vegetarian like 10 years ago. So I know things are changing. And with industrialization and the pollution, we're going to have a lot of respiratory allergens. Yeah, so yeah, I thought I should, put that out there. Yeah. So I will share the information on reduction of aero allergens. Reading food labels is key to avoiding food allergens. Reading food labels is very key. If you go to a restaurant, let them know. They will ask you. Most restaurants these days will ask you whether you are allergic, and you tell them yes. Tell the chef that you are allergic to so and so, and they would know. They will take that into account when they are preparing the food. Avoid Chinese and Indian restaurants because they use a lot of nuts if you have peanut allergy. So Chinese and Indian restaurants, takeaways do use a lot of nuts.
Well, thank you very much for this talk. I think I'm biased a little bit. Dr. Letu, I think we can. Do you have time to take 1 or 2 questions?
Please go ahead.
Okay, so let me also say this, at least we made progress from what we used to have back home. We have an active allergy society in Nigeria, and I'm going to speak to that at the end of this talk. Any other question or chat? Any other question? I think. Okay, Dr. Fadri said
1 or 2.
So Dr. Fadri said, thank you for the excellent talk. Do children really outgrow allergies? Is there a risk for severe reaction in future exposure?
Good. Yeah. Sorry, I think is echoing now. Yeah. So so they do, and in fact, they may actually outgrow most allergens. But we know for sure that egg allergy, a lot of children would outgrow it by the time they are 1, so 1 year and above. And like I said, we would normally start cautious egg reintroduction using what we call the egg ladder, even from the beginning, unless you have like an anaphylaxis. The other thing to point out with egg allergy is not a contraindication to the MMR vaccine, which is cultured in chick embryo, because that used to cause confusion. And flu vaccine is not contraindicated to. So we use the killed flu vaccine and not the live ones. Yeah, but that's a different thing. So yeah, so egg allergy definitely. And I tell my patients, if I was going to choose an allergy, I would choose egg allergy. Cow's milk protein allergy, we know, again, majority of children would outgrow it by the time they are 1 to 2 years. A few more would outgrow it by the time they are 3. But I think what is becoming obvious now is that there are people developing egg milk allergy later in life. So we're now having adult or later onset milk allergy, which actually tends to be more of IgE mediated and associated with anaphylaxis, whereas the typical milk allergy that we know that starts in early infancy and gets better as people get older rarely presents with anaphylaxis, or in fact uncommonly presents with IgE-mediated responses. It's mostly non-IgE, but that pattern is changing. In terms of NOTs, we usually say that NOT allergy is for life. But in reality, studies, again, if you look at the BSACI guidelines, studies have suggested about 15%, up to 15% of children with peanut allergy, which started in very early childhood, say infancy or soon after, up to 15% of them would outgrow by the time they are 4 or 5. So that's 15%, right? So we say it's essentially for life. But when people are older and they're beginning to wonder, do I have to avoid this for the rest of my life? And they're very keen, you can rescreen them and then do, especially do the component resolve diagnosis, look for RH2 levels and skin prick test. And if things are better, you could do a hospital challenge for them. And a few of them may have outgrown it. Fish allergy, fish and seafood, we say for life. Once you have those allergies, you are for life. But in reality, a small proportion of children with allergies, whatever the allergies will be, would outgrow them. That's my understanding.
Thank you for that. Can you please speak to the issue of oral immunotherapy for peanut allergy? It's something you practice in the UK.
Yeah. I think all allergens are amenable to immunotherapy. Recently in the UK, in fact, the studies on immunotherapy for peanut actually started ages ago. It started several years ago, even in the UK, until we had 1 or 2 mishaps, and then everybody forgot about it. But it carried on in Europe. More recently, Parfosa, I think you guys would have heard it, has been approved for oral immunotherapy for peanut. This is basically peanuts made into capsules, and with different strengths, starting from little micrograms and building up. So the whole essence of immunotherapy is that if you gradually expose the body, the immune system, to the allergen in question, you over time fool the immune system and they begin to accept that allergen. So with peanut, they've managed to commercially produce capsules with peanut that you can use to do desensitization. And that's been approved by NICE. So NICE is the National Institute of Clinical Excellence. They are the body that kind of look at, treatments and approves the one that we can use within the NHS. So it doesn't always agree with what is out there, in America and other places, but NICE is what we go by. So recently they approved this treatment for oral immunotherapy. Now, most of that happens in private practice now in the UK. So places like London, Harley Street, a lot of private practitioners there are offering immunotherapy. Very few NHS organizations. I don't know about Lola, you might know about Southampton. Southampton is one of the big centers. I'm not sure whether they're doing it now within NHS, but certainly in the northwest here, where we've not started offering it. All right. What people are also talking about is what they call real-world peanuts. So rather than use the commercially prepared peanuts, which is very expensive, and it just has peanuts, people are talking about using real-world peanuts. So they are kind of making their own peanuts in small, making it, starting with very small amounts and exposing the children to it. So basically it's there, but I think it's not taking hold in the NHS, but private practice, they are using it a lot. And it's very expensive. Yeah.
Thank you, EMEKA, for the very wonderful talk. I really enjoyed this talk, and I think you have also helped me market my program. We have a conference happening later next month. It's World Allergy Training School that we partner with American College and Wahoo. So I'm sure the synopsis have actually helped to market the product. So like I said, even for me, at least, I actually followed the same track that you followed. As a medical student, I didn't know a lot of allergy, so we pursued that thing and we're trying to build bottom up. And I'm sure we'll actually partner. I'm trying to look, the reason why I asked whether you're coming home is that maybe anytime you come home, we can actually make something happen for you to be part of that. Yeah. So thank you very much, everyone. So like I said, because Elito asked me to do this, so I'm marketing my program. It's very cheap. and going to have a very nice experience. Marriott Hotel, good food, dinner for free, and a lot of knowledge that will be shared. Thank you, Lutu. Over to you.
Thank you. So I'm going to leave now. So thank you very much for having me. I'll send some leaflet. But if you go to the Northwest Allergy Network, you will see all, we have quite a lot of leaflets there. But I'll send the one on house dust mite reduction. I'm sure people are going to benefit from that. Thank you very much. Thanks for having me. A real pleasure to talk to you guys.
Thank you very much, EMEKA. It's been nice having you.
All right. Thank you.
And at some point, I'll get across to you again for another talk.
Yeah.
And like the moderator said, anytime you're in Lagos or you're in town, please let us know.
Yeah.
So we can have a drink.
I'll keep in touch.
Don't worry. 1 pint will make us drunk. So,
and
we don't
yeah,
have any
I'm quite accessible. Anybody with any queries, we do a yearly allergy conference, British Society of Allergy and Clinical Immunology conference, yearly. I don't go every year because it's expensive, but if anybody's interested, they could. If somebody's, we also do Northwest Allergy Study Days. That tends to be March. So again, if anybody's in the UK around that period, they could give me a shout, find out when it's happening, and if they are keen, then they may well be able to attend that. Thank you very much. It's a real pleasure talking to you guys. I'm really pleased. Thank you very much, and bye-bye.
Thank you.
EJ, bye-bye.
Bye.
Okay, we'll chat later. Thank you.
Thank you.
Bye-bye.
So,
thank you,
Bye,
Bye-bye.
Thank
Bye,
you.
everyone. Bye.
I hand over to you, Dr. Mbolaji Lawal.
Well, it's been a good day. It turned out to be both interesting and informative. I look forward to seeing the recording. Thank you, everyone. Thank you, Dr. Odushote. And I'm happy you marketed your program. And I want to lend my voice to it. Everyone should please register for that program. And
I will be there.
I'm happy that for this meeting and that it's opened up some kind of avenue for collaboration.
Yes.
And I like collaboration, and so I'm really pleased at this event. Thank you, Dr. Odushote, for coming, and Dr. IKPAKWU, Dr. EMEKA Elewa IKPAKWU has left now, so please convey my special gratitude to him. Thank you all for attending.
Thank you very much, sir. And just to put Damilola on notice that I'll be contacting her, since she's also giving quite a bit of information, so that we can arrange some talk at some point in time.
And there's no free lunch.
There's no free lunch. So on behalf of the president, I want to thank everybody who's been on this call and waited patiently, and hope to see a few of us at the conference at the Marriott next month. And until we meet again last Thursday of the month of September, all the best. Bye-bye for now.
Bye-bye, everyone.